everybody see that okay?
Right there behind
There we go. Is that better? All right. So technically this is 2021. Not much has changed, but the numbers are actually from 2020 for the most part because the numbers for 2020 will not be ready till probably the end of this year. So, all right. So we're going to do a quick overview of, does everybody know me? Do I need to introduce myself? I'm sorry.
I've never seen you before.
All right, so we're going to talk about disease transmission as a reminder on how it goes. So you have your infectious agent, and then how infectious it is depends on the dosage and the virulence of the germ itself. Some things are definitely more virulent than others, and then sometimes we get exposed to more than, if we're closer in the back of an ambulance to somebody, you're going to be exposed a lot more than I am if I'm the whole 6 feet rule, stuff like that. And then you look at your means of transmission. Was it direct or indirect? So typically in EMS, we don't have a whole lot of direct contact. We're not kissing anyone, hopefully. Some people hug patients, but not very often anymore since COVID started, and stuff like that. So most of the time it's indirect for us. And then you look at your routes of exposure. So we have airborne, bloodborne, contact, and droplet, all different ways we can get exposed to stuff. And then you gotta look at your host, and there's resistance versus protection. So we all know protection is gonna be something like a vaccine. Your resistance is gonna depend on your own immune system and on your own health at the time, and stuff like that. So then you have our body's natural defense, which is our skin. I also apologize for my voice. Again, you guys missed it. I told everybody that my sister passed away 11 days ago, and my voice is really angry from all the crying that I've done, and I haven't fully recovered it. So, pardon me. And then there's allergies. This pollen is awful. And if you go, the further south you go, the worse it gets. I've been in Newport News for the last 11 days, and wow, the pollen there is way worse than here, which I didn't think was possible. All right, so unbroken skin is the body's first line of defense. You have natural antibacterial oils on your skin, which is why antibacterial soap is the worst invention ever. My dad went to get knee surgery, he had a knee replacement, and they actually made him wash his whole body with antibacterial body wash for a week before his surgery. I thought that was kind of interesting. A week. And I'm like, that's terrible. There's so much good bacteria on your skin. Washing it off is a terrible idea. So organisms cannot pass through your skin. Some of the skin's normal secretions are bactericidal, like they said. I mean, the human body is amazing at protecting itself, but we do some stuff to like make that not work as well. So how do bloodborne exposures occur in EMS? Most common is through a needle stick, contact with mucous membranes, and then cuts from other contaminated equipment. I've witnessed a few needle sticks, but I've actually experienced more mucous membrane exposures. Like I was ventilating this guy that shot himself in the head, and not only when I ventilated, blood shot out like about 3 feet to the side, but when I got to the hospital, somebody's like, "What is that on your face?" And my glasses and my whole face were spattered with blood. I had no idea. I was just, ventilating, and I didn't feel like anything coming this way. It shot on the provider next to me, which that was a little funny. But when I got there, I was like, wow. So then I had to go wash my whole face. And, we didn't wear masks back then because COVID wasn't around, so I probably inhaled some of his blood too if it was spattered all over my face. A very light mist. So then I just washed my face and washed my glasses and went about my day. And then you have cuts from other contaminated equipment. That's, very, very rarely do we use like a scalpel or anything. But let's say somebody got in an auto accident, the vehicle kind of the metal like bent and wrapped around the patient, got blood on it, and then you scrape yourself on it, that blood, the patient's blood then gets into your blood, can get into your bloodstream from that way. Or like I said, scalpels and stuff like that. So how is communicable disease spread? So we talked about direct contact. So that's physical contact with the source. Indirect contact, so that's touching objects that have been in contact with the source. That can happen at Walmart and at all kinds of places, at church and stuff like that. That happens a lot. And then airborne, so that's breathing in droplets that became airborne when an infected person coughs or sneezes. What are some diseases that are airborne for sure? Tuberculosis is 100% airborne. It's not droplet at all. So if somebody with tuberculosis sneezes right here, and I come up and go like this, and then I lick the French fry juice off my fingers, they say you can't get it that way. You have to directly breathe the particles into your lungs because it only enters through your lungs. I just learned that actually a few years ago. Vector-borne, through bite from an infected animal or insect. What's the most famous one around here? Ticks. So nasty. So how bloodborne exposures also occur is contact with blood or other potentially infectious materials, OPIM. So semen and vaginal secretions, shouldn't be getting too much of that on us. If you are, you might be doing something wrong in the back of an ambulance. Pleural fluid, does anybody know what pleural fluid is? It's the fluid that lubricates your lungs, it's your lung oil. CSF, cerebrospinal fluid. So, I mean, you can come in contact with that pretty easily if somebody has a bad, like an open skull fracture or something. It can come out their ears, even if you can't see the open skull fracture. Synovial fluid, typically if you're in contact with CSF, there's blood involved, almost always. Synovial fluid, anybody know what that is? In your joints, your synovial membranes. It's joint oil. Pericardial fluid, around your heart. If you're in contact with that, something really bad happened if you've got exposed to pericardial fluid. Peritoneal fluid, belly oil, make sure everything's nice and lubricated and slimy. And then amniotic fluid, yep. And then any fluid visibly contaminated with blood. So saliva is not on this list, because if somebody with HIV spits in your mouth, you're not going to get HIV from them unless they have a cut in their mouth and there's blood mixed in with that saliva. Or they bite you, and then it's, but again, if they don't have blood in their saliva and they bite you, the blood is your own. So even then you're okay, but you're probably going to get an infection because they bit you. So you still need to get treated, but not for HIV or anything else. So statistics, again, these statistics are old because you should go on I spent hours on the CDC website doing this PowerPoint to get the most recent statistics, and the only solidified concrete ones are 2017, 18, 19. To get up-to-date numbers, it's not even possible. All right, so at the end of 2018, there were 1,040,352 adults and adolescents with diagnosed HIV in the U.S. and dependent areas. In Virginia, 12.1 per 100,000 is the estimate. Here's your link if anybody wants to look at it. Again, that's all on the. You can find any statistic on the CDC website. It just takes a long time for them to tabulate, calculate, and finally update it. So in 2018, 37,968 people received an HIV diagnosis in the United States. From 2014 to 2018, HIV diagnoses decreased 7% among the adults and adolescents. However, annual diagnoses have increased among some groups. Of the 37,968 new HIV diagnoses in the United States, 69% were among gay, bisexual, and other men who have sex with men. 24% were among heterosexuals, and 7% were among people who inject drugs. Excuse me. For every 100 people with HIV in 2018, 65 received some HIV care, 50% were retained in care, and 56 were virally suppressed. So this is an important number for us because HIV treatment has come to a point where it's not necessarily fatal anymore. It used to be life-limiting, and now it's just life-altering, where these people just take medicine for the rest of their life, and they can live another 20, 30, 40 years because they can be virally suppressed with medications to the point that it's not detectable in their bloodstream, and therefore it's not damaging their body, and it's not making them as susceptible to all these terrible infections that usually kill them, and it doesn't progress from HIV to AIDS, which AIDS is the stage in which you die. So it's pretty impressive, actually. Hepatitis B, ignore this chart here. It's not as good as I once thought it was. So nationwide cases, 2017 is the most recent statistic. I'm not going to be able to say that word. Stat available. 3,409. And then Virginia had 61 new cases. And here's your chart on how it's progressed through the years. Let me grab my water real quick. So you can see from 2011 to 2018, stayed pretty much the same, gone up a little bit, down a little bit, then back up again. Hepatitis C, new cases nationwide, 3,216, but they estimate 50,300 because it's very underreported, and a lot of people, they know from research that a lot of people have it, and they don't know that they have it. And then in Virginia, there were 62. So, hepatitis B and C exposure report. So there were 0 hepatitis B or hepatitis C outbreaks among EMS workers from 2008 to 2019, according to the CDC report. Most outbreaks, when they say an outbreak, that's like greater than, I think greater than 3 people in one given area. So that's what we mean when we say outbreak. So most came from long-term care facilities and dialysis centers where they had an outbreak of a whole bunch of people that got it. Tuberculosis. So that's taken off a little. The most recent statistic is from 2019. So nationwide, 8,920. Virginia had 205. And again, for PPE, we use airborne precautions. Must be inhaled to infect you, like we talked about. An N95 mask protects you from it. And then you need to maintain good ventilation. So we have that cheesy little vent in our ambulance. Doesn't work very well in my opinion. My fan in my bathroom sucks more air than that thing. But we're still supposed to turn that on and open the windows to give us the ventilation we need. And then distancing when possible of 6 feet. The crazy thing is it stays in the air for 6 hours. That's why you need to ventilate, because if somebody with TB coughs in your ambulance, it can like linger. And we all know that here in Virginia, when it's like stupid humid and there's no air movement, like a fart could linger for like 3 hours, right? Tuberculosis is the same thing, okay? So ventilation is really important, and you can see on this map, the darker areas are above the national average, and then the lighter areas have the least amount of cases, of course, where there's the least amount of people. But you can see Virginia is kind of right there in the middle. And in my whole career, I never transported anybody with active TB until 2 years ago, and we had 2 in 1 year, which was really weird. And one of them was for MedExpress, and that's where he got diagnosed by chest x-ray. And he looked really sick. And he had traveled back and forth all around the country for the last year. He was like a international student type person. And wow, yeah, I can't even imagine how many people he contaged, if that's a word. So some diseases are on the rebound in the U.S. Measles were 63 in 2010 and 1,282 in 2019, thanks to the anti-vaxxers. I think we talked about this last year. Mumps, 2,612 in 2010 and then 6,109 in 2017. Pertussis, or whooping cough, which is like the worst thing on the planet. 18,719 in 2011, 32,917 in 2014, and then 15,662 in 2019. There was a big outbreak, and this is part of the reason that they went down is because the CDC realized that this in particular, that your immunity that you got in childhood, if you got all your vaccinations, has worn off as we got older. So now they recommend anybody over the age of, I think it's 21, go get a booster and get revaccinated against it, because the anti-vaxxers sent their kids to school claiming whatever exemption, and a bunch of teachers they had pertussis, and then the teachers started getting it really bad, and that's where this big boom in 2011 or 2014 came from, because I remember we had an outbreak in Madison County, a town of 14,000 people, and I think there was like 21 or 27 people who got it in Madison County, which is, like I said, kind of small like Rappahannock. It was a little shocking. But a lot of them were adults that got it from like a kid. So, chickenpox, gone down significantly because the vaccine came out in 1990, we'll cover that in a minute, 1995 or 1996. And it has significantly decreased the suffering that we all went through, the itchies, and all that kind of stuff. The numbers are amazing. Here it is right here. So the red line right here is 1995, and that's when the varicella vaccine came out. And you can see these dramatic change in the numbers. Now, I was a reluctant parent. My son was born in 1997. I was like, that's a brand new vaccine. I'm not letting my kid get that vaccine. I want to wait and see how it goes and how everybody does with it. And then eventually I gave in. I was like, yeah, he's a little old to be getting the chickenpox now. We'll go ahead and get it. And I didn't hear anything bad, stuff about it. So finally got it. I think he probably got it in like 2001-ish. So chickenpox used to be very common in the United States in the early 1990s. Our parents had parties when one kid got chickenpox. Everybody, let's go, come on. We gotta go give you chickenpox so we can get it out of the way. Thanks, Mom. So an average of 4 million people got chickenpox. 10,500 to 13,000 were hospitalized. Who knew? That's like a lot. And 100 to 150 died each year. So in the 1990s, the highest rate of varicella was reported in preschool-age children. The vaccine became available in 1995. And then in children and adolescents less than 20 years of age, varicella deaths declined by 99% during 2008 to 2011 as compared to 1990 to 1994. I think this speaks very highly of vaccines, in my opinion, and how amazing they can be. And I'm praying that we get the same result from COVID vaccines at some point. So this is just another chart that kind of shows how the deaths went and how everything declined significantly. Mumps. So here's your mumps cases, starting in 2000, going to 2019. You can see there's been some booms here and there. But it's gone up a lot higher. If you look at 2000, we have much higher numbers consistently. And again, one person decides to publish an opinion that vaccines cause autism, and that's all she wrote. And this is where we are today. So boosters. So every adult should get the Tdap vaccine once if they did not receive it as an adolescent to protect against pertussis. So they're giving all adolescents now, and they're 10 to 14 age range are getting like a booster, but we all didn't get that because they didn't come up with that until recently. So talk to your doctor and go get it, because vaccines are free through your insurance company if you have insurance. And if you don't have insurance, you can go to the health department and get them really, really, really cheap. And it's worth it, because go on YouTube and type in whooping cough, and you'll see the most horrible images and videos you've ever seen of people literally coughing so hard they can't catch their breath. They look like they're dying. They feel like they're dying. It is one of the worst things I've ever seen. So, tetanus and diphtheria booster shot every 10 years. We always know, got to get that tetanus shot. And the ER always asks you, when was your last tetanus shot? And then they say that women should get the Tdap vaccine each time they're pregnant, preferably at 27 through 36 weeks. Talk to your doctor. I'm not a doctor. I'm just saying what the CDC says. All right, we're going to touch briefly on COVID-19. He said he just did a COVID-19 update, so he's probably going to correct some of this. But the key is prevention, PPE, wearing a mask, deconning your ambulance really well. Do you guys spray your ambulances? Okay, you guys use the ultraviolet light one? So in Company 12, we have vinyl oxide that we spray our ambulances with, and our cots and everything. We've blocked off the front to the back because we have like some walkthroughs still and stuff. Not all of them have the little window. So I know Company 11 actually took plexiglass and just drilled it in, because we have like plastic and tape. But they just put actual plexiglass in their walkthroughs. Ventilation is necessary. Our masks save lives. Ventilation is definitely necessary. Again, turn on your ventilation fan. They recommend that you have your vent fan on in the back and your windows open in the front, so there's like a, pull the germs out. But if you blocked off your cab from your back, it doesn't matter. But open your windows and turn your vent fan on. Make the patient wear a mask. It can be placed over a non-rebreather. If you've never put a surgical mask over a non-rebreather, it works well. Take a shower. If you have been around somebody in the back of an ambulance, especially if the patient cannot wear a mask, or we all know that some of these people, even though we're not supposed to be doing the particle, what's the word I'm trying to come up with? Aerosol generating, yes, aerosol generating procedures like NEP treatments or CPAP or something like that. We're not supposed to, but sometimes we have to because they're dying, right? Or if we have to ventilate somebody. When you have a call like that, you definitely need, and your hair or anything is exposed, you need to wash it. So we do mask, gown, gloves, and all this. I actually bought hair covers, the kind that when they dye your hair at the salon, little plastic shower-looking caps, and that's what we wear because I couldn't find the surgical ones that they have in the OR. Those have been, I finally found some on Wish recently. But I wear that and cover my hair, and when I get to the hospital and I get out of the room and I take all my PPE off, I go over to the sink and I wash my face, any part that was touching. If I don't have time to wash my face, I literally hand sanitize my face. Whatever was not covered by something. Because those particles can land on you, and they do die outside of the body fairly quickly, but not so quickly that I'm writing my report and I'm like this, and I don't, get it on my hands and then rub my eyes or eat a bag of chips. So, wear a mask in the hospital at all times, because we know that's where all the sick people go. So, that's really important. And then stay healthy. Take care of yourself. Exercise on purpose. If anybody stays from my last class on the well-being of the EMS provider, we're going to talk more about exercising on purpose. All right, so these are from February 26, 2021. I was getting daily emails from our director, Bill Uten, and that stopped for a while. And again, given my last 11 days, I didn't have time to go in and research this and update it. So at that time, Culpeper was at 4,064. Hospitalized were 166 and deaths were 50. Fauquier is kind of the one I was comparing to this whole time. Y'all have like 15,000 more people in your county than Culpeper does, yet we've been ahead of you guys the whole time. But at that time, you guys had 3,937. Hospitalized was 159, deaths was 51. So, and then, going on down, and then little Rappahannock's at the bottom down there, 298, 15 hospitalized and 2 deaths. And again, this is, I'm sure, changed significantly since then, especially because right now I hear there's a new boom coming, and a lot of people got vaccinated. A lot of people are like, I'm vaccinated, I don't have to wear a mask. So again, protect yourself and others, wear your PPE, use your safety equipment. This is for every germ, not just COVID. Dispose of waste properly. Supposedly, the CDC says that PPE from COVID is supposed to go in a red bag. Who puts it in a red bag? But that is what is directed. Get your immunizations. Get a COVID vaccine if you can. Make sure you go get your pertussis booster shot and stuff like that, and flu shots. Good hand washing. Always practice universal precautions. Review your exposure control plan, and then know your designated infection control officer. And then disinfect properly after calls. Who's your designated infection control officer here?
Wayne.
Who?
Wayne Dodson.
Wayne Dodson? Okay. So here's a few reminders. So if you received your MMR vaccine between 1963 and 1967, revaccinate with 2 doses, 1 month apart. Hepatitis B vaccine. If you haven't been vaccinated for it, I highly recommend that you do. This is one of the easiest things to catch in EMS. Hepatitis B is very, very hardy, virulent bug. It can live on surfaces for 7 days and infect you for 7 days when it's on surfaces, even if you can't see the blood. So if somebody comes and does a half-assed job of cleaning up some blood, and they've wiped it enough that you can't see it, but they haven't left it on for the proper contact time to kill the germ, to kill hepatitis B, and I go like this, and then I lick the french fry juice off my fingers, I could still get hepatitis B. A large portion of healthcare providers who have gotten hepatitis B don't have a known exposure that they can remember. So, yeah, it's bad. So get your hepatitis B vaccine. It's one of the easiest things to avoid in this field. Tdap booster, MMR, chickenpox, flu vaccine, TB testing. I know in Culpeper, UVA WorkMed does TB testing once a year on us, but if you talk to Kathy West, she says you're not supposed to do it yearly. Only if you get an exposure. Do it one time for a baseline, and then if you're exposed after that. So it's hard to document immunity. You can get when I did my paramedic clinicals, I either had to get a varicella titer to see if I had immunity, or just go ahead and get the vaccine. So I just went ahead and get the vaccine. Vaccine's free. It was $300. My insurance wouldn't pay for a titer. So I had the chickenpox and I got the vaccine. So it's the cost benefit, just getting vaccinated if you have to prove it. Then we're going to talk a little bit about norovirus. So most outbreaks of norovirus happen when infected people spread the virus to others. It can also spread by consuming contaminated food and water and touching things that have the virus on them. If you've never had norovirus, it's the worst thing ever. Every liquid in your body is coming out of your mouth and your bottom, sometimes at the same time. So avoid it at all costs. When I have a patient who has nausea, vomiting, and diarrhea, I am mask gown gloves just to make sure, because myself, Bill Uten, and another person that was with us, all three of us caught it from one patient, and we were miserable. 24 hours after we transported this patient, all of us had it. And his wife had just put him in the shower and cleaned him off really well for us. There was no signs of poo. It didn't smell like poo. Their house was spotless. We just helped him up off the chair onto the stretcher, and that was enough to get the particles on us, because it only takes a tiny, tiny, tiny bit to infect you. So, healthcare facilities, including nursing homes and hospitals, are the most commonly reported places for norovirus outbreaks in the United States and other industrialized countries. Over half of all norovirus outbreaks reported in the United States occur in long-term care facilities. Nursing home patients, one gets it, everybody gets it. So, restaurants, schools, banquet halls, summer camps, cruise ships, they've had it like more than 25% of the people on a cruise ship get it all at one time. Can you imagine those poor medical people having to deal with like everybody having it? And most of this is related to handling food, because again, it only takes one person that doesn't know how to, goes in and wipes their butt and doesn't know how to wash their hands very well to give it to an entire cruise ship. Literally, that's all it takes. Because it's not airborne, it's oral fecal, so it has to come from the poo. So, norovirus is the leading cause of illness and outbreaks from contaminated food in the United States. About 50% of all outbreaks of food-related illnesses are caused by norovirus, and they usually mistake it for food poisoning, because you go to a restaurant, you eat, and then you get the poops and the runs, and they're like, oh, it must be food poisoning. No, somebody didn't know how to wash their hands after they wiped their butt. They went and used the same utensils, and the occurrence of norovirus has gone down significantly since COVID, because now, has anybody eaten at a buffet since COVID started? So me and my kids just ate there last night. Well, I've done it several times since COVID started, because I cannot stay away from the Chinese buffet. It's like my favorite. And so, but now what you have to do is you go in and you put, they call them deli gloves. They have boxes sitting everywhere. You walk in and you have to put the gloves on before you go up and grab all your food. And then you take your plate back and you take your gloves off. So if they've been doing that all along, norovirus might not even exist in this country. So that's kind of exciting. I feel safer now eating at a buffet than I used to. So, hepatitis C can survive for up to 16 hours on surfaces. Hepatitis B for 7 days on surfaces and still have enough illness to infect someone even if you can't see blood. We already talked about that. But good news about HIV is it dies within minutes of being exposed to air. So HIV blood could be like all over, and you're not going to get sick from it if it's been more than a few minutes. So that's why hepatitis B vaccine is the most important. Of course, there is no vaccine for HIV or hepatitis C. But Hep B is the strongest little germ. It's unbelievable. We're going to talk about tick bites. So tick-borne illnesses, especially in this area, are very common. And I've transported quite a few people. I transported somebody with Rocky Mountain spotted fever that he got from a tick bite, and he was paralyzed. And he was hoping that it would go away eventually, because it can when it's the result of a tick-borne illness. But this was a young, healthy farmer. This guy was only like 39 or 40 years old, and now he was paralyzed from a tick bite. And he literally just got a really high fever, didn't know what was going on, went to bed, woke up, took some Motrin and Tylenol, woke up the next morning and couldn't move his legs. It's just life-changing. But you have all these other ones. Lyme disease is the most common, but you have I'm not even going to try and say it, yeah. Anaplasmosis, and that other word. You have your spotted fevers, those. But you can see the incidences are fairly high, especially for Lyme disease. But Lyme disease is one of the most underdiagnosed tick-borne illnesses, because the testing sucks. There's a really high false positive or really high false negative when they test for tick-borne illnesses, because the amount of that illness has to be high enough to detect in blood work. And so if somebody didn't know they have it and they get tested, 4 months later, and all this damage has been being done to their body, but like the viral load isn't high enough to see it, or the bacterial load rather, you just can't see it. So yeah, it's some bad stuff. So we're going to talk about what to do if you have an exposure. Number one, administer self-care. That's the most important thing. Flush your eyes and your mucous membranes. Thoroughly wash the needle stick. Use whatever you have on hand. If you're out in the field and you don't have a sink and some water, use hand sanitizer. It'll burn, but it'll be worth the burn. Get that nice and clean, and then wash your non-intact skin or wounds thoroughly with whatever you have available. And then dispose of the hazard if possible. So get rid of that needle. Don't let anybody else stick themselves with it. Then like, well, technically there's two patients. Like, it's their blood, then my blood, and now they got it. We don't want that. And please, if anybody here is a medic, do not stick needles in the seat of the ambulance. That's pretty old school, but I've heard of people doing it recently. So, not the right place for a sharp. That's mostly gone away with the needle safe devices, but like, you know, some stuff is not needle safe. The Vacutainers, do you guys draw blood on patients? So the scary part is that I've set that down on the seat and had providers that didn't know there's a needle inside of it. It's covered with a sheath, the rubber sheath that pushes down when you put the blood tube in it, and then when you pull it out, that needle's sitting there under that, and if you accidentally stick your finger in it, you get stuck. And that's a hollow bore needle full of blood. So that's really bad. So make sure that everybody knows, first of all, what that is and how to handle it. Because there's some driver-onlys, right, that aren't even EMTs and might not realize that, and I never thought about that, especially when I'm on a volunteering ambulance with people who don't know very well and who haven't had my class. So be very careful and dispose of your sharps immediately if possible. Sharp on the floor is not acceptable anymore either, really, because most of the time in ambulances we have sharp box within reach, but people used to be like, start a line, pop it out, drop it, be like, sharp on the floor, expect everybody to remember. And to stay away from it. Okay, so then we want to report it immediately. When I say immediately, I mean like immediately as soon as the call is over. Obviously you can't stop in the middle of the road and be like, hold on, I have to call the infection control officer. So as soon as a true exposure occurs, it's very important to report it because we have to get the patient tested. So call your designated infection control officer, night or day. Whoever yours is, they might not appreciate a call at 2 a.m., but it's the job that they hopefully know that they have to do. So report the exposure to the attending physician and the charge nurse where you transport as well, because they're going to get their infectious control people at the hospital involved, and you're going to get your designated infection control officer involved, and those are the three people that are going to be involved, and then test that patient and see where to go from there. And then fill out the paperwork as soon as possible, day or night. Like I said, it may be 3 in the morning, you may be really, really tired, but the details are going to be freshest in your mind, and that report needs to be ready first thing in the morning so that things can start happening if you do need treatment of some sort. Very, very important. And the biggest reason for this is that, again, it's easier to test the source patient while they're still at the hospital than try and knock on their door and be like, hey, somebody got exposed to your blood, we need to draw some from you and see where you're at. The hospital, if they know about it, will do that for you. If that patient leaves, hopefully not before you leave, if that patient leaves, then it's a lot harder to figure things out. And then follow all instructions given by your infection control officer or the physician or whomever you're going to be listening to at that moment. There's a defined process for assessment and treatment. It's documented in your county's or your department's infection control plan about how everything's supposed to play out and about how everything's supposed to go. And there's a defined follow-up process. Some of these things you get tested, on some exposures you're going to get tested immediately for a baseline, and then in 3 months and then 6 months to make sure nothing is developed, because HIV doesn't show up right away. If I get stuck today, it's not even going to show up in my blood work in 2 weeks. So there's a big follow-up process. It's imperative that you do all the follow-up procedures and all the care, because if they do give you some kind of preventative medication and you don't take it like you're supposed to, then you might get hepatitis something or other, A, B, C, D, E, F, G. So this is all confidential and covered under HIPAA. Again, it's your decision if you want to tell somebody. If I'm going to be like, hey, Art, I'm really worried, I got exposed the other day, right? then that's my responsibility. But if she's the designated infection control officer and she tells anybody in this room, she just violated HIPAA, and you can sue her for like $10,000. Yeah. So keep that in mind. It's supposed to be confidential. If your partner is the one who gets stuck, you're obviously going to know about it, and it's your job to keep that confidential. If the person who got exposed wants to tell people, great. If you do, it's a HIPAA violation. And it's rude, like really rude, not nice. So, after a potential exposure, there's no evidence that supports using antiseptics or expressing fluids by squeezing the wound will reduce the risk of bloodborne pathogen transmission. So if you get a needle stick, you don't have to sit there and be like, get out, and try and get the blood out. Because you just need to wash it. You need to put some hand sanitizer on it immediately, wash it with soap and water to the best you can, because again, squeezing it will not help. Important things to know, we already decided who our designated infection control officer is. Where is your infection control plan located? The radio room, okay? And is your infection control plan up to date? When it should be up, it definitely needs, the most important time for it to be up to date is when the inspector comes, because when the state comes to do your yearly, it's every other year they come, right? When they come to do that, they can ask anybody in the building to show them the infection control plan. They may go ask her and him, all in different places, show me, to see if y'all know. So it's important that everybody in your department knows that it's in the radio room. And then they may look at it and make sure that it's up to date. So you have to make sure you have, like, take a stamp that says today. Really important. And then we'll talk about the source. So is the source available for testing? They do not test needles or other sharps, so you do not save the sharp because they won't be testing that for anything. If the source is known to have an HIV infection, consider the stage of the infection. If the infectious state of the source is not known, they do a rapid HIV test, hepatitis B and C testing, and then your county algorithm in your infection control plan will define everything else. But again, we talked about how important it is to have the source available. And we talked about, too, about people being virally suppressed. So the good news is, if you know that your patient has HIV, but you know that they're virally suppressed, the hospital is going to do blood work on them, and if it's undetectable in their bloodstream, then it's actually still reported as an exposure, but not treated as an exposure, because then it's like getting exposed to blood that doesn't have HIV in it. That's the good news about these days. So the source blood will be tested. They have something called a SUDS test, which is a rapid HIV test. That can be done while you're waiting. Hepatitis B hepatitis testing might be sent out to a lab for testing. It could take several days to get back. A friend of mine was exposed through blood that shot up into her mouth, and the patient knew. She's like, I'm so sorry, I have hepatitis. She had hepatitis C. Oops. But she actually never got it. The amount of blood that went in her mouth was pretty significant too. And she had to like hold pressure until her partner got in there to hold pressure, and then rinse her mouth out, spit, brush her teeth. I think the patient had like mouthwash, and she just like threw the Listerine in there and everything like that too. But she ended up not getting it, thank goodness. And then the hospital personnel should contact your designated infection control officer with all the lab results. And again, your infection control officer knows these results. You know these results, and the hospital person knows the infection control person knows them. That's it. Unless you choose to tell them. You can tell everybody you want, but other people can't. All right, that's it. Any questions?